Hi everybody, this is Farah Farhati. I'm presenting a short video about how to formulate an answerable question in public health services research. The World Health Organization suggests to use the PICO or PICO's format. In PICO's, P stands for patient, population or problem, or population with the problem. So when you are collecting the information and evidence about your study, you need to collect all the information about your target population. So, and subpopulation with a specific problem or disease or severity of the or stage of the disease, comorbidities, and all the other patient characteristics or demographics. For example, you need to collect the information about the age, gender, ethnicity, country, and if there is a control group. So if you're looking for the differences in the prevalence rate of a specific disease among African American compared to the white American, then you need actually to specifically collect information about the differences in the prevalence rate between these two group of the population. So that could be basically absolute value, the number of the patient, and also in terms of relative values, the percentage of the population to compare these two groups of the population. So when you have this PICO, you start with the population with the problem, then you have to collect the information about the size of the problem, size of the population with this problem, maybe in terms of the percentage and absolute value. I stands for intervention, which refers to the specific treatment or approaches with the patient or population. So, for example, it includes the dosage, frequency, method of administering treatment, and so on. So, it could be actually a policy, for example, a smoking ban in the building. And then C stands for comparison. So, that could be a current standard of care or could be basically a placebo, different drugs, or surgery and different, basically lifestyle changes. So you have to, when you determine your intervention and comparison, you have to have enough, you have to provide enough information for the readers to describe and justify the type of intervention and comparison, why you selected this intervention and comparison, and why they are the right actually comparison to be compared. O in PICOS stands for outcomes. But basically the outcomes describe the specific results of interest. We are comparing the outcomes in terms of short, intermediate, and long-term outcomes, and it includes the areas such as both cost and effectiveness in terms of quality of life, complications, mortality, and morbidity in terms of number of inpatient and outpatient, and etc. So you are comparing the outcomes with intervention and without intervention or with the comparison group. So to determine whether this intervention was cost effective or not. So this outcome should be basically should be in terms of numbers to compare basically the cost effectiveness. For example, we can determine the outcomes in terms of both supply and demand side. In terms of supply side, you can determine the availability of the healthcare resources, such as number of the physicians or hospital beds available per 1,000 patient. And from the demand side, you can actually show these outcomes in terms of utilization of the healthcare, number of the outpatient, inpatient, and even mortality rates. So you have to be careful to choose the right outcomes that are basically evaluating the intervention, impact of intervention. The setting, S in PICO stands for settings. So the settings that are affected by this intervention, for example, whether that intervention increase the number of the outpatient, decrease the number of the inpatient, or any other type of settings in our healthcare system. For example, if our intervention is increasing the number of the patient, the number of the people to have access to care, means that increasing the number of the insurance. So definitely that is increasing the number of the outpatient. And when the people they actually go to their primary care doctor and control their chronic diseases, that will decrease the number of the inpatient and emergency room. So you have to basically control for both of outpatient and inpatient in that case, because if you just control for one of those, your evaluation will not be accurate. T in PICOS stands for time. The time describes the duration of time to measure the impact of intervention on outcomes. Most of the study, they can follow the patient's outcome for 6 to 12 months. But the perfect timing would be the lifetime to include all the side effects and long-term effect of intervention on the patient. Let's start with an example. The first example for PICO is the pneumococcal conjugate vaccine. So the title is the Public Health Evaluation of Infant Pneumococcal Conjugate Vaccine in the United States. The research question is, from a societal and a healthcare system perspective, what is the cost effectiveness of infant national immunization program from birth up to 5 years old against pneumococcal pneumonia disease in the United States? The keywords are usually the same as the title and the research question. So both title and research question, they have to include the keywords. And with these keywords, you can actually conduct a search in different, basically online, to search for the evidence and literature, peer-reviewed or public data to complete your collection of the evidence related to the studies you're looking for. The primary target population in this study are the total birth of 4.16 million in 1990. So we are looking for basically the total population. They are good candidate for this vaccine. The secondary target population is basically 84% of the children in the United States, they have PCV coverage, not all the 100%. The intervention is the PCV and the comparison are without the PCV. So we wanted to basically evaluate the outcomes of healthcare with and without this PCV. So that would be the increase or decrease in the number of the outpatients, inpatient admission, antibiotic prescriptions, and total costs with and without intervention. The settings of our interest are outpatient as well as hospital admission, ventilation for ear and lung infection, and antibiotic prescription for streptococcus pneumonia. There are two timings that you have to mention in literature review. One is the following the health outcomes of newborn for 20 years, and the other one is the inclusion of the um, articles in your research study. For example, here the peer-reviewed articles are included from 2000 to 2018. The second example of PICO are the atypical antipsychotics for patients with schizophrenia. So the PICO question is for a patient with schizophrenia in Ontario, Canada. How do atypical antipsychotics compare to each other in terms of clinical effectiveness, including benefit and harms in Ontario, Canada? The target populations are an estimated 0.6% of Canadians will develop schizophrenia at a point in their lives. But not all these 0.6% of total Canadian population are using the atypical antipsychotics. Only 76,282 patients are using the atypical antipsychotics. So these are the target population. The interventions are atypical antipsychotics, and the comparator are atypical antipsychotics. So atypical antipsychotics, there are four of them: risperidone, olanzapine, quetiapine, and clozapine. So we are comparing these four with each other to see which one are more cost effective compared to the others. The outcomes without interventions are prescription medication costs for schizophrenia are increasing basically over the past few decades. Increased from 48 million in 1996 to 150 million in 2004. So with intervention, the risperidone remained the least costly under different scenarios, and the model suggests that starting with risperidone, olanzapine, or quetiapine will cost the healthcare system about this much respectively for the first 12 months of treatment. The third example of the PICO is a case study of Nexobrid, which is a burn treatment product. So what is the potential economic spillover benefit? Means that indirect benefit of the effect of initial investment of $24 million in Nexobrid, which is a burn treatment product, if we use it in the day-to-day healthcare routine, assuming 25% market share. So this means that this product is invested by public for $24 million. Basically, the Department of Health and Human Services paid to the MediWound industry to develop this product for the case of when and if nuclear bomb happen, for the burn injury from nuclear bomb. But the point here is that nuclear bomb hopefully never happen. How we can actually collect our return on investment if basically hopefully never this nuclear bomb happen. Now maybe we can use this product in the daily routine care for the patient with a wound, actually usual regular fire wound, and we wanted to know how long, basically after how many years, we can get our return on initial investment of $24 million. Now the primary target populations are number of the patients with radiation wounds from nuclear bombs. We have no idea if ever happened nuclear bomb, how many people would be injured. So we don't have those information. So therefore we have to go to the secondary target population, which we will actually collect our return on investment. Means that let's use them in the daily routine care in the hospital. So then if the hospital buy these products, after how many years we can get our $24 million back. So the average number of the annual eligible patient with a burn wounds age between the age of 18 to 69 with a less than 15% of total body surface area is 22,314 patients from the American Burn Association data. So only these 22,000 annually they are eligible to use these NexoBrid. So those people with the higher than 15% burn wound of total body surface area, they are not eligible based on the FDA instruction to use this NexoBrid. So the intervention is the debridement by NexoBrid. What is the comparison? Right now, the standard of care is that 70% of the patient with the burn wounds, they go under surgery, and 30% they use the mechanical lavage, mechanical irrigation, etc. So basically, this NexoBrid is like a very similar to the toothpaste. The surgeon put that on the dead skin of the burn wounds, and can take off the dead skin and prepare the skin for grafting the new skin. So basically, this debridement by NexoBrid decrease the number of the number of the hours the surgeon works on patients. So basically, decrease the number of the stay in hospital. Now, the outcomes are the incremental economic spillover of debridement. What are the input? The most important outcome is the hospital length of stay. How this new intervention can decrease the length of stay in hospital compared to the standard of care. And the timeline for the calculating the outcomes, evaluation of the outcomes for intervention is 10 years. Because the MediWound, the industry which actually launched this NexoBrid, has the patent protection for NexoBrid until up to 2029. Assuming that the FDA approved this product in 2019. So this MediWound has the basically privilege of patent for 10 years. The setting is basically hospital, and the main parameter of interest is the length of stay in hospital. So let's see how we can calculate the spillover effect. First, we have to calculate the number of the patients with this specific TBS under 15% and between age of 18 to 69. And so 16,000 of these patients, they require debridement, and 6,000 require autographing. Now we have to see the change of the length of stay in hospital and the cost between the intervention and the comparison group. And of course, over the years, not all the 100% of the hospital, they adopt this NexoBrid. So starting with assuming 25% of hospital adopt this, or 50% in the other extreme side, we have 75% market share, the hospital adopt this NexoBrid. So this multiplication of number of patients and changing the length of stay in hospital and cost multiplied by market share basically provide us with the economic spillover or indirect benefit from this NexoBrid. Why is indirect? Because the direct effect was basically the primary target populations are the patient with injured with the nuclear bomb. So the indirect benefit is the patient in the routine care with the burn wounds. So the key parameters we can determine is the incremental length of stay in hospital with and without NexoBrid, incremental cost of treatment, and the market share determines the cumulative economic spillover of the benefit over 10 years. So, what is the potential economic spillover benefit effect of initial investment of $24 million in NexoBrid, which is a burn treatment product, if we use it in the day-to-day healthcare routine with incremental treatment cost of 3,654. What does it mean? Means that NexoBrid is 3,650 more dollars more expensive compared to the standard of care. So we wanted to know what is the length of stay saving with this NexoBrid. If the NexoBrid stay was 1.3 days length of stay saving compared to the standard of care, and if we assume that market share is 25%, so therefore we have a break-even point of $24 million in 1 year. As the market share increase, we have a positive rate of return, and basically as the length of stay saving increase, we have higher positive return on our investment. So it's very important to have a kind of looking at what are the key elements and key input output that we are looking for. So the results, the government investment of 24 million would break even at various parameters values for the peak market share. So the one key parameter is the market share, and one key parameter is incremental cost, means that the difference between the cost with the intervention compared to the standard of care, and the effectiveness, which is the reduction in the hospital length of stay for NexoBrid versus the standard of care. So the net annual potential spillover saving from the debridement and grafting is projected to be 6.9 million if we assume 100% market share. But as this, basically assuming this market share are different in different range with different lengths of stay hospital saving, then the outcomes would be different.